Hello, everybody. Good morning, good afternoon, good evening, in the words of the good Dr. Tedros. How are you today? I have my good friend Sonda Kunzi with me today. She and I are going to dive into the medicine section together. Sonda, thank you so much for joining me today.
Oh, absolutely.
This is a National Maple Syrup Day. How do you feel about that? Do you maple syrup?
Uh, I think I lost you. There you go. All right. I lost the noise or the sound for a minute there, but yeah, I'm into
Oh,
maple syrup. We actually produce it here in our county. We're big producers of maple syrup.
oh, nice. Absolutely. Yeah, I'm a fan. It's also National Say It Now Day. I'm not real sure what that means.
Yeah, me either. But whatever it is, I think now that I'll just have a reason because it's National Say It Now Day. So I'm just going to start saying things
Oh no, it's
like
gonna be all
I'm
Christine
not
salt.
cooking dinner. Sorry.
Awesome. Well, we wanted to talk a little bit about the medicine section. And Lexi, I think we got some reverb. Can you fix that? She can fix anything. Ah, awesome. I think she did. So, one of the things that we were talking about is how the medicine section it includes some of the same specialties that we see in the surgery section, but the medicine section is really intended to be those non-surgical therapeutic interventions. And so I think for me, when I think of that, I think of some of the other specialties that maybe surgery is not the go-to, like psychiatry or physical therapy. Hopefully, my physical torturist is not going to do surgery on me. Uh, and I know that you have a
Yeah.
big specialty experience with psychiatry.
Yes, absolutely. Love the behavioral health section. Luckily, we didn't have very many changes. In fact, it's pretty much same, except for some great new green printing, which means we have a little bit more guidance here and there.
Absolutely. And a few things with psychotherapy codes. I wanted to remind people that these codes are timed codes. We've got some great description on how
Yeah.
to report those timed codes. And when we're doing psychotherapy with a medication management or a medical visit, just to remind that we got to be careful about not double dipping times, right? Do you see that?
Yeah, absolutely. Yeah, for sure. And just a reminder to everybody, when you have an E&M and you're going to do an add-on psychotherapy, your E&M needs to be by medical decision making.
Absolutely. Now, there's some other specialties that have a unique approach to time. For instance, our physical therapy, occupational therapy, speech language pathology, they're allowed to report those codes once they've met the midpoint. And in 2024, CPT actually did a really awesome job in the instructions, which a lot of people don't read. Um, I go through the book because I'm just that big nerd. Oh, I want to see the green writing and all the new instruction. But they did give us some clear guidance on time and the midpoint for some of those therapy codes.
Yeah, as well, didn't they? I mean, there's been a ton of new information in the CPT book. I mean, I know we're talking about the medicine section, but goodness, the front end of this CPT book this year, incredible. And it does affect some of the things in here because the QHP lands in this section kind of.
Absolutely. And they gave us some great definition on telehealth and the use of telehealth, which we have a lot of codes in the medicine section that are on that appendix Q and appendix T, or is it P and T? I forget sometimes. That can be used either audio only or
Yeah.
audio video. And there's a list there. A lot of those codes are from the medicine section.
Yeah. Isn't it funny sometimes when we can't remember the exact appendix? It's like there's so much coding in your brain that some of it leaks out. It's just the way
Well,
it
I
is.
also found as I get a little bit older, some things leak out, right? Make room for new things or things that are important, like the E&M section that constantly evolves. Oh, it's P and T. P and
Oh my
T. Those are
goodness.
the two. Yeah.
B and T.
Yes.
All right.
So one thing to remember is that AMA puts out those codes, right? They give us all of the CPT codes. Now they don't say it's going to get paid. CPT never says anywhere in the book, cover to cover, trust me, friends, or read it yourself, that they're going to pay for every code that's in the book. So just because there's a code doesn't mean it's going to get paid. But what the AMA is saying with those two appendixes is that these services, we as the medical experts in the field feel that they can be provided either audio video communication or audio only communication. And if you use these codes during telehealth, please give us a modifier to let us know that you're using them. Never do they say Medicare is going to pay for this or commercial is going to pay for this, or, so you always have to check your payer policies to see what services will or will not be paid, right?
Yeah, I totally agree with this. I think that a lot of times as consultants, we do get brought the question, well, there's a CPT code for that. I used it. I don't know why I didn't get paid. And you have to kind of back it up and say, yes, they do provide CPT codes for services that they recognize, but it doesn't, I would say, commit a payer from accepting it. And yeah, that's sad, but true.
Absolutely. Another thing that is definitely delegated by time, and I'm also glad that we got some very clear definition in the instructions, was infusions. How many times does somebody show up to the
Mm,
ED, or an infusion is started at 11 o'clock at night and it continues through the midnight hour?
mhm,
Do we bill for 1 hour today and then 2 hours tomorrow? No, they gave us great examples that said, listen, just continue the time forward. It started today at 11. It's a 3 hour infusion. Give the date of service today and the initial hour of infusion and 2 additional hours of infusion, and leave it be, folks. And that's the correct way to report that. So I thought that was pretty awesome that they gave some additional guidance in the 24 book. And then, of course, that's the guidance that we're going to continue in 25.
yep.
The Go ahead.
Yeah, I think that every year, yeah, I was gonna say, I think every year there's a little, I don't want to say little nugget that comes out that the AMA is like, I think people don't understand this. So we're going to produce a little bit of an explanation here and a little bit more of an explanation. I think I've seen over time that we've gotten more detailed and less vague. Now, mind you, when we talk about CMS and some of the policies and things that come out, there's still vagueness, but I think CPT and the AMA has done a really great job of trying their best to say, here's what we mean by this.
Absolutely. And I just did a presentation on Saturday. We were chatting about that. And one of the things that was more, for me, more interesting than just some of the new CPT codes. I mean, they were really cool. Watching the category 3 become a category 1 for 25. That's super cool.
Mhm.
But what was really interesting is all of the tabular guidance, the parenthetical notes that are coming into play. We're seeing that, when there is a new
Mhm.
code being added, we're getting so much more parenthetical note, like do not use with, or if imaging guidance use, and they give you the codes. And I when I'm teaching, I'm constantly reminding students, like, the concept of coding doesn't end at the code. That's just where it begins. Now we go through and see, do we have a semicolon? Do we have an indented code? Do we have plurality? Do we have the parenthetical note where they say, if it's bilateral, use a modifier? They give us so much in CPT.
Mhm.
And every year, that, for me, that's the exciting part.
Yeah, it is. And we're both probably geeks about the green. The green wording is really awesome.
Absolutely. So the elephant in the room was the hiccup that happened last year in the medicine section with the administration of COVID codes. So
Mm.
the AMA had a last minute change. In 23, as we started to see more and more manufacturers of COVID and the guidance came out with, we were having a second vaccination, booster vaccinations that were coming out. If you were over the 6 months old, there was one recommendation. If you were adolescent, there was another recommendation. And so CPT had essentially originally created administration codes depending on whether it was the first dose, the second dose, the booster dose, over 6 months, over 12 years old, all kinds of crazy admin codes. And at the end of the CPT book, they actually developed this table, Appendix Q, and it had like multiple pages of what administration code. Anyway, long story short, they came in at the last minute after all the books had been printed and they were like, no, just kidding. We're going to delete all those and we're going to replace them with one admin code. Hope you get the message. And then, of course, this for 2025, he reiterated it. Did you catch that last year, Sonda?
Yep, sure did. I mean, those are things too. It's really important to be on top of all the stuff that does come out when they make changes to the CPT and also the AMA. I really feel does a good job on their site on changes and giving instructions to providers.
They really do. And if you're not participating in the AMA's CPT editorial panel, all of those minutes, whether the short version or the long version, they're all available on the AMA website. You're looking for the AMA editorial panel meetings. They're quarterly meetings where they discuss what's proposed to change. And if they're going to change it, when do they propose to change it?
Yeah, I honestly have found this to be highly informational, especially if you are working in a specific specialty that's looking to get new codes or something's on the horizon, or in our case sometimes just in a consulting role, we kind of almost know ahead of time like, "Oh, that's on their agenda. Let me like pay attention. That's going to be talked about and we want to make sure we're on top of it."
Yeah, and now's a really good time to reach out to your consultants. Consultants are not part of your full-time staff. We come in simply to tell you what can we expect on the horizon? What are the changes on the horizon? Oftentimes we work directly with your compliance team. And as we are finishing Q4 of 2024 and we're looking at Q1 of 2025, there's a lot of things that we've got to consider. Those changes, not just CPT changes, ICD-10 changes, modifier changes, the policy changes. This is a great time over the next week to kind of go through your CPT codes that you provide mostly in your practice and look at those payer policies. What insurances do you participate with? What services do you provide? Has that guidance changed? Will it change for 2025? And how are you going to roll those changes out to your practice, your providers, your ancillary staff, so that everybody's ready to go on day one?
Yeah, correct. And in the section we're talking about, the medicine section, like you said, it's sort of like call it like everything in the kitchen sink. You have a little ophthalmology in there, you got some cardiology, PT, we got, the psychotherapy codes and the rest of behavioral codes in there and vaccines. Oh my gosh. It is a really important section of the CPT.
And I think every specialty participates with some codes from the medicine section, whether you're administering an injection in the office, whether there's wound care happening. A lot of people have taken advantage of the education codes that are out there to help with caregivers, educating caregivers, remote therapeutic monitoring. A lot of these interactive kind of services that have been rolled in that you might be providing in your own practice.
Yeah, agreed. And just to kind of springboard off that, the remote therapeutic monitoring has a ton of green writing. Um, and it's something you definitely want to read, especially if you're considering those services. And right now it is a pretty big ticket in behavioral health because of the cognitive behavioral therapy end of this particular thing. I just don't, it's really hard to envision, getting treatment for cognitive behavioral therapy on an app, but really, I'm a little older, maybe I'm old fashioned, so it's out there, it's available, and they're talking about it quite a bit.
Absolutely. And again, I think this is a great time. Um, so what I've heard out in the industry is that a lot of a lot of the codes were added because these are services that our providers are already performing. And when I meant the codes for like remote therapeutic monitoring, the cognitive behavioral monitoring, some of the different assessments that are out there, a lot of the caregiver interaction.
Mhm.
If we look at that final section in the medicine section where we're really looking at a lot of the care management services or the other services that are being provided by the qualified healthcare professionals rather than just the physicians, we're going to see that, CPT has done a great job of trying to provide a code that represents services that are, that's going to help capture some of that revenue for the time that your qualified healthcare professionals are performing these services. And then maybe you're not capturing them. Maybe it's a good time to kind of reevaluate, look at the practice as a whole and see, what services do we provide for our patients?
Yeah, totally agree. I mean, every year is a great year to kind of every year is a great year. That's kind of funny. Just say it. That's what today's theme is.
Just
Every
say it.
year it's important to look through the CPT because you might be surprised that what you've been doing and you're like, "Oh my gosh, there is a code for that." And again, we won't guarantee payment on that, but it's a recognition at least to the service you're providing. And I'm a fan of always billing for what you're doing even if it doesn't get paid. Now, in that aspect, you never want to get out of line with that. But in general, if you're providing a service that does as a CPT code, you just want to account for it, even though
Hmm.
a carrier may not pay for it.
Exactly. And then again, lots of new codes or revised codes like the online digital assessments. One of the
Mhm.
the mixed measures is that we encourage all of our patients to use the portal. I I use the portal. My provider probably thinks I abuse the portal. Um, but my husband and I both, we have found it really easy to log in, use that portal and go back and forth. And ironically enough, like I've mentioned it to my primary care doctor. I'm like, listen, I bombard you with lots of questions in the portal. These are clinical questions. The portal is designed to for me to ask you a clinical question. If it were authorization, I click a different button. If it were prescription refill, I click a different button. But when I'm asking you clinical questions, you can aggregate that conversation for 7 days and report a code depending on
Mhm.
how much time you spent going back and forth with me for 7 days. And, I know that that might be a little hard for the provider to keep up with, but imagine that if you've got a champion in your office that helps navigate the portal messages, they might be able to help capture that time and to report reimbursement for that service. They're probably already doing it.
Yeah, I would agree. And I think sometimes it's just like you said, administratively, it can be difficult and it depends. You do need that superstar internally in your office who understands these type of things that can keep the revenue flowing for the things that you're doing currently and maybe not getting paid for.
Absolutely. Absolutely. So we've got a lot in this section that, there's not a lot in the guideline. The guideline pretty much just tells us that there's a lot of add-on codes. Be careful with the add-on codes.
Mhm.
Um, tells us that there are separate procedures. So make sure that when it's delegated as a separate procedure, that you're actually performing that completely separately than another procedure that is like it at the same time on the same day. So I almost say paint a picture of it, like Sonal Patel always says, paint the medical picture. If you do have that, and this is throughout the entire CPT book, guys, if you see something that says separate procedure, think about it this way. If it's a surgical procedure or a medicine procedure, did the patient come in, get prepared for it, have it done, leave, and then maybe come back and have a separate one done? That would be the definition of a separate procedure. But if we're doing it all at the same time, moving from one to the next, you really don't have a separate procedure. So even like I say, like a colonoscopy, if you're having a colonoscopy done and you go in, they put you in the little awkward
Mhm.
gown, they get you on the table, they give you some anesthesia, something happens, you wake up in the recovery room and you get the fill in of what happened. When the doctor's in there, if he finds a polyp, he takes it. If he finds a bleed, he cauterizes it, or she. If they find something suspicious, they take a biopsy. They don't wake you up in between each one of those procedures, make you go back out into the waiting room, get dressed, right? Wait for the anesthesia to wear off, and then do it all over again 3 times in a row. Like, we're laughing, but truthfully, that's the definition of the separate procedure. So was it
Totally.
completely separate? No. No, and if you wake me up in the middle of a colonoscopy, we're not gonna be friends.
Yeah, and on a smaller version of that, right? And in the medicine section for when you bill psychotherapy, there is this other code 96127 that identifies a little test that might be a PHQ-9, and it's not payable on the same day. But think about that. You're in psychotherapy, you're going to question your patient about how they're feeling, what are they doing? Have they felt depressed? That's why it's not separately billable. These are the things we're kind of talking about. These are why we see the guidelines or why there is such thing called NCCI edits and things like that.
I'm glad that you mentioned that one because I usually have a great conversation with my providers when I see that code or I see the
Mhm.
G0444 for the Medicare patients. And I tell them, the other thing that's really important that we forget is medical necessity. And a lot of times providers, if I come in to have a
Mhm.
splinter removed from my finger and you're going to do an assessment, either a behavioral assessment or a PHQ-9 assessment, maybe it's because you've got to meet some MIPS measures that you've selected for that reporting year. But what would be the medical necessity for doing a PHQ-9 when I came in for a splinter? I mean, it would probably depend on how I obtained the
Yep.
splinter, but, if I was just lifting a wood table and I got a splinter, I don't think that that really would justify from a medical necessity perspective the the reporting of it. At what point did you feel that
Mhm.
me lifting that table supported doing that PHQ-9? So again, I understand that it could be a MIPS measure, but we've got performance measure codes that might be a better way of reporting that MIPS measure rather than trying to get reimbursed for something that really wasn't medically necessary at the time.
Yeah, for sure. I mean, in the services that I provide in consulting, I've actually had a group say to me, well, this particular insurance carrier during COVID said every patient should get one. And I was like, that doesn't sound, and it was the entire practice that said, oh, yes, we all heard it. And then when I called, they were like, no, we would like that once a year on all of our patients.
Unless there is a medically
Oh,
necessary reason why you feel like I come in, it's the holidays, I'm a little blue. I was expecting to get a new Mercedes for Christmas and that didn't happen. So, and I'm not making light of mental health, please, by no means. But again, as a provider, they might think that that was a justifiable reason to do a PHQ-9. We would see something in documentation, that would prompt that or support that. But otherwise, the annual check-in for the PHQ-9 is best done during their preventive visit, where we're just going in, no
Mhm.
signs, no symptoms, trying to see where they are and reflect upon where they were last year.
Agreed.
Yeah, there's so much to think about. Sometimes I'll say just because there's a code doesn't mean that there's a good reason for you to report it today. It's got to be medically necessary. It's got to show a payer where what you're doing has a benefit today, at today's visit. Because that essentially, any of those codes that we're reporting for their relevance today, psychotherapy today, um, that we're seeing the hydration today, that we're seeing the immunizations
Mhm.
today, right? We're not looking at what could happen next week, week after. Though we'll deal with that when that comes. But we're looking at what was done today and what was the goal of today.
Yeah. And sometimes they lose sight of that. And I think some of the pressure on the providers for all these quality measures and HEDIS and all this, they almost feel pressured to add these things when it's not necessary. So I think that in some instances, I know you agree that the healthcare industry and the way they do things have kind of pushed it on our providers to, oh, you need to measure this. And then what happens is their staff goes, well, there's a code for that, rather than thinking maybe, like you said, a quality code versus an actual service code that gets paid.
Yeah, yeah. That's why I truly, truly feel that, again, we're in Q4. It's a great time. Call me, call Sonda, call your consultant and say,
Mhm.
let's do a peek at where we are. Let's put together a projection of what we want to see for next year. Maybe add, if you are providing any service from the medicine section, maybe a focused review or focused audit, a focused monitor of those codes that you're reporting and see if there's a better way to report that. Is there something more strategic? One of the practices that I work with, I always recommend in the beginning of the year is a great time to schedule those preventive visits for those healthy patients. A lot of times we have deductibles that are out
Mhm.
there, preventive visits are usually covered at 100%. That's a good time. And to do some education to make sure that you're capturing all those performance measures at that visit, at that encounter. And that kind of frees you up for the rest of the year to just focus on practicing medicine. Let's be smarter about this. Let's not be harder. Let's be smarter about it.
Yeah, and also recognizing there is some being strategic in the business of medicine. Those annual visits at the beginning of the year keep the provider from, hitting all the deductibles, right? Because usually, just saying usually, preventive services are paid without a deductible or coinsurance. There's some that follow that. But in general, that's a good way of continuing your revenue for the beginning, and it serves the patients very well. So it's a win-win, and I think it's a good idea as well.
Absolutely. I couldn't agree more. So, Sonda, we are at time. Is there anything that you want to leave our listeners with regarding the medicine section? A little tidbit, a little tip? I know you do a lot of behavioral health. Oh no, did we lose Sonda? Well, what I want to leave you with and what I want to remind you about this year is please make sure that you are checking your upcoming CPT book. Look for those green letters, those green instructions. Also, now is a great time to take a look at the maybe top 25 services that you provide in your organization. Review those policies. Were there any changes? So as we move into the next year, 2025, we have understood all of those requirements. Check out those parenthetical guidances. And whether it's the medicine section or any other section that we've covered this season on Coding with Christine Hall, Again, make sure you're reaching out to your compliance folks for clarity, your coding folks for the up-to-date codes and how to use those codes. I want to thank Sonda so much for joining me today. Hey, there you are. I was asking if you had any final tips for our listeners today.
Internet can't handle it. Yeah, so make sure you see some of the new there's new COVID vaccines that are in there. There's a couple of different changes to the vaccines because flu vaccine changes all the time in dosage and things like that. And there's a couple other things in ophthalmology, but not a ton, but it's really, like I said, good place for you to spend some time to look to make sure you're not missing any of those things.
Absolutely. I couldn't agree more. And I want to thank all of our listeners for a wonderful 2024. I'm looking forward to the next season next year, 2025. I couldn't imagine a better person to wrap up the year with. Sonda, thank you
Thank
so
you.
much for coming on the show. Remember, you can always reach out to myself or Sonda if you have any questions whatsoever. We're here to help you and to help your practice be successful. And we wish you all a happy holiday. We wish you a happy, happy new year. We look forward to talking with you all next year.
That's awesome. Thank you so much.
Thanks.
Thanks for watching.